Good morning and welcome to the Young Physicians Forum of the Ceylon College of Physicians. So we have two speakers lined up today. So we will start with the first speaker, and also just like previous time, so we will have 25 minutes of the speech followed by 5 minutes for questioning. So our first speaker is Dr. C. Chandana Dahanayaka, MBBS, DTCD and MD in Medicine. He is the Senior Registrar in Respiratory Medicine, and he is attached to the National Hospital of Sri Lanka for Respiratory Diseases, Valisara. So he's going to talk to us on a pragmatic approach to diffuse alveolar hemorrhage. Over to you, Chandana.
Thank you, madam. Good morning. Thank you for your kind introduction, and thank you, college, for giving me this opportunity today. My talk will be on a multisystemic disorder, which the pulmonary manifestation will be a diffuse alveolar hemorrhage. A good clinician will detect the clinical signs, and we need a radiological input, pathological input, as well as the laboratory data to diagnose this condition. And you feel a bit of boring with this topic, but I'll be try to do it as simply as possible. So this is my outline. Right. We see some patients presenting with this diffuse alveolar shadows, especially to medical wards and to the respiratory wards. And we encounter this respiratory distress and hypoxic respiratory failure. Nowadays, it's almost always COVID until proven otherwise. And they do present with sort of hemoptysis. We know there are plenty of causes for hemoptysis, and the well-known mnemonic is battle camp. And sometimes they present to the medical wards with anemia. So, thinking all together, is this a possibility of diffuse alveolar hemorrhage? So, what's the definition of diffuse alveolar hemorrhage? It's a clinical pathologic syndrome of pulmonary hemorrhage that originates from the pulmonary microcirculation. I'll start with the case. A 43-year-old male, he's a healthcare assistant, presented to our national hospital with a shortness of breath for 6 months, and he was investigated there, even with bronchoscopy had been done, and no cause was found. He was presented to there with exertional shortness of breath and hemoptysis. No causes were found, and on MEA at the presentation, his saturation was 90. Other than that, he's hemodynamically stable. So you can see the chest X-ray, there's not much of a difference, and you can appreciate the basic investigations which were done there. It looks normal. And in the Hrct, what he came with, there are some nodularities and subtle ground glass opacities. So, is it a case of DAH? You will be know after this my talk. So, what are the components of diffuse pulmonary hemorrhage? This comprises of three main entities. The main bulk is the pulmonary capillaritis, diffuse alveolar damage, and the bland pulmonary hemorrhages. The pulmonary capillaritis, the hallmark of the pathology is the inflammation of microvasculature. And what about the bland pulmonary hemorrhages? There's no inflammation, but the RBCs leak into the alveoli. In DAD, the pathology is a bit of different. There's no inflammation or extravasation, but the hallmark of the pathology is ARDS, that we know that in early ARDS, it's edema, hyaline membrane formation, and leading to organization and fibrosis. This is the simple diagram to illustrate the pathophysiology. In your right hand side, it's the bland pulmonary hemorrhages where the alveolar cells undergo apoptosis and leakage of red blood cells. And in the other side, it's the immune-mediated capillaritis leading to the neutrophil necrosis, and the extracellular trap will damage the alveolar membrane and ultimately leak into the alveolar space. So we all know the vascularity, the large, medium and small vessel vascularity. So in this topic, we are much emphasizing about the capillaries and the small vessel vasculars. So as we all know, in the picture here, you can see the neutrophils infiltrating the interstitium, and ultimately it's leading to this kind of picture. So what about the etiology? There are systemic disorders, and mostly the vasculitis and connective tissue disorders. The examples are the ANCA-associated vasculitis and most of the CTDs. In localized diseases, there are mainly the diffuse alveolar damage and the inhalation injuries. The examples are the idiopathic pulmonary hemosiderosis, SLE, and some coagulation disorders, and most of the drugs. What about the DADs? Mainly the ARDS, as I mentioned, and infections. And don't forget the bone marrow transplantation, which we come across in pediatric patients. So, in the other aspect, we can categorize the etiology according to the pathological evidence. That means the capillaritis, whether there are capillaritis or not. So there are different categories. The primary idiopathic small vessel vasculitis like ANCA vasculitis, IPPC, the isolated post-immune pulmonary capillaritis. And there are primary immune complexes mediated vasculitis like HSPs and good pastures, and secondary vasculitis, SLEs, and most of the CTDs. And there are the systemic conditions like after bone marrow transplantations, Behçet's, and drug-induced causes. Bland pulmonary hemorrhages are mainly without capillaritis, so there won't be any evidence of capillaritis, as I mentioned. Good pastures is the example. So 90% of the cases in good pastures, there's no capillaritis, the bland pulmonary hemorrhages. And idiopathic pulmonary hemosiderosis, and the most of the coagulopathies are, we can't see the evidence of capillaritis. And the bone marrow transplantation and infection, as I mentioned. So the diagnostic approach, we need to establish the diagnosis of DH as the first place, and also to identify the underlying cause. It's mainly clinical. A good clinician will not miss these features, the foot drops, feet drops, and the episcleritis, those so on. We should actively look for that, and the radiological evidence and the pathology. But laboratory workup and the early bronchoscopy is also important in diagnosing. So what's about the clinical presentation? It may be acute, subacute, or there may be repetitive patterns. So we must consider the DH in patient with otherwise unexplained alveolar infiltrates. So what's the presentation? Hemoptysis, but apparently it presents in 1/3 of the patients. Cough, fever, dyspnea are other vague symptoms, and they may present with acute respiratory distress, which need the immediate ventilator support. Again, a proper history is much more important. Recent infections like leptospirosis, Hunter, hepatitis C with the associated cryoglobulin, we know how bad they present in medical wards with leptospirosis. Like, we are in a great fear if we get a patient with leptospirosis. And drug history. Some of these drugs will cause ANCA vasculitis, that we all know, and exposure to toxic agents like pesticides and all. At the same time, we should look for systemic conditions like collagen vascular diseases, mitral valve diseases, and the history of solid organ or stem cell transplant. Again, when they present with these signs and symptoms, we should look for the suggestive features of vasculitis. When they come with acute glomerulonephritis or pulmonary renal syndrome, or when we see a deforming or ulcerative upper airway diseases, and when we detect a cavitary or nodular disease on chest imaging, when we see palpable purpura, like I mentioned, the mononeuritis multiplex, and any other multisystem diseases. So the upper airway and GI bleeding sources must be excluded. In some instances, we need to exclude upper GI bleeding with the help of gastroenterologists to do the endoscopies and all. Then again, a congestive cardiac failure, pneumonia, and other causes should be excluded. Like, we know there are plenty of causes for diffuse pulmonary shadows, like in PCP pneumonia, in immune compromised, even heart failure, even eosinophilic pneumonias, like so on. What about COVID-19? Of course, it's a must. We should exclude COVID-19, and even repeatedly we should do the PCR and all. And now the imaging the new addition to the list is COVID-19. So these are the same thing, that the eyes, nasopharynx, skin, renal, and good neurological examination will warrant the diagnosis. So what about radiologically? Chest radiograph and Hrct being the most sensitive tool, and it's characterized by a non-specific alveolar filling. Diagnosis or suspicion of TH needs to be supported by the clinical features. And we know the CT is superior, and this is much more important. We should do a CT even with normal chest X-ray if we are suspecting a DAH. So in chest X-ray, we can appreciate these bilateral shadows. Usually the apices are sparing, and also we can see any other pathologies like curly B signs and nodules. So what about the Hrct? In acute phase, there may be ground glass opacities, and we could appreciate the dark bronchus sign. You can see the patent airways are much more translucent than the peripheral lung parenchyma because the underlying ground glass and the mosaicism. And after 2-3 days, there may be interlobular and interlobular septal thickening, as this image. And there may be some crazy paving pattern. So again, there are plenty of causes for crazy paving, and the new addition, don't forget, is COVID-19. They often can resolve. So in between, there may be centrilobular nodules like this, and that reflecting the interalveolar accumulation of pulmonary macrophages. And with repeated hemorrhages, there may be interstitial fibrosis. So we can see in our console, it's as like this. What's the place of bronchoscopy? We need early bronchoscopy, and it confirmed the hemorrhages and to exclude the infections like TB. And we detect the rising RBC count or the rising color in sequential bar laliquors from the same location. More than 20% hemosiderin latent macrophages is diagnostic. And in pathology, they used to calculate this Goldie score by analyzing the content of hemosiderin latent cells. Usually, type 0 is no hemosiderin, and type 4 is the CV1, and they give a score. So laboratory, this is the basic laboratory that we do in day-to-day in our medical wards, and we need to do the specific immunological markers as well. A small word on ANCA. We know the CNCA is highly sensitive, and it against PR3. PNCA is non-specific, and it usually against MPO, and even in rheumatoid arthritis, good pastures, it can be positive. Anti-GBM antibodies is again highly sensitive. We can diagnose even without a tissue biopsy, but it's remained the gold standard. But when the diagnosis is questionable, we can go for an open lung biopsy. And if we suspect a good pasture, so ANCA vasculitis, and even the renal profile is supportive, we should go for renal biopsy. And we should do the histopathology and immunofluorescence. So you see how important the clinical history and the clinical signs in a patient coming with hemoptysis, alveolar infiltrates, and anemia. There are certain instances that we should come across presenting without those clinical signs and symptoms. So one instance is anti-GBM disease limited to the pulmonary form. So in that case, positive GBM antibodies with linear deposit in the lung will be evident. There are pulmonary limited MPA. In that case, positive MPU antibodies will be present. Post-immune isolated pulmonary capillaritis, the diagnosis by biopsy. And idiopathic pulmonary hemosiderosis, we can see in younger age, usually the diagnosis of exclusion, and the pathology is bland pulmonary hemorrhages. I'm very sorry for this busy slide, and there won't be much time to go on these single diseases that we all know. And especially this EGPA and granulomatous with polyangiitis, we should differentiate. EGPA comes with asthma-like feature, and there will be peripheral blood eosinophilia that is characteristic. So, what about the treatment? They are consisting of treatment of underlying cause, management of pulmonary hemorrhage, treatment of hypoxia. The mainstay of treatment is corticosteroids and immunosuppressive agents that remain the gold standard. Plasmapheresis, there's evidences even for, like we know that it works for GBM and recent evidence for ANCA vasculitis. Newer therapies like recombinant factor 7 and IV tranexamic acid also. Then we need to do the hemodynamic correction, blood transfusion, infection control, ventilator support, oxygen supplementation, and mechanical ventilation with higher PEEP to produce a tamponading effect. So we need to get a medical intensivist to intensive help in that case. So the backbone of the treatment is early identification, remission induction, and the maintenance. When we talk about the remission induction, we know in vasculitis there are limited diseases, early generalized diseases, active generalized disease, and severe disease. So in the context of this diffuse alveolar hemorrhage, we are much more important about this active generalized disease and the severe diseases. So in active generalized diseases, we usually go for cyclophosphamide pulsing with corticosteroids. And in severe diseases, usually we go ahead with the combination therapy, cyclophosphamide or rituximab with corticosteroids and plasmapheresis. And there are refractory causes, diseases, where the usual therapies will not work. In that case, there are IVIG, infliximab or TNF-alpha and T-cell depletion therapy. So this is the study on this combination therapy. Nowadays, it's controversial to use rituximab because we know that it causes severe COVID pneumonia. So corticosteroid, they recommend to use the high standard doses for 3 to 5 days pulsing and gradual tapering. But at the same time, there are studies on low doses, and they say that the overall mortality did not differ. A word on plasmapheresis, it eliminates the autoprotective antibodies, and usually it used in specific instances like anti-GBM disease and cascosity vasculitis and SLE, and like we know that leptospirosis, severe hemorrhages. And it should be mentioned, it's important to know that it's only an adjunctive therapy, right? So this is a study done in the teaching hospital Karapitiya with severe leptospirosis hemorrhagic syndrome, and we had promising results. So this is a PEXIVA studies, landmark trial and the recent study done for the plasma exchange, and this had a comparison with the MAPEX which was done a few years back. That was plasma exchange versus artemether-prednisolone. And in the PEXIVA study that they have done it to about RPGN and for diffuse alveolar hemorrhages, and in that study it says there's still insufficient evidence and we have to use it as an adjunctive therapy, but alone we can't use. Then a word on rituximab. It's also again alternative therapy. It's non-inferiority induction of remission, also to maintenance of remission, and it's superior to azathioprine in disease remission over 2 years. So those are the trials that they have done on rituximab. A word on recombinant factor 7. We know that it has been used for hemophilia and antibodies to the factor 9 and factor 8, and it has been used in pulmonary medicine for massive hemoptysis, and it's considered as off-label in this DAH. Maintenance usually with this azathioprine and methotrexate, and nowadays it's using MMF, much more common, and leflunomide, cyclosporine, and even rituximab is being used. Usually the maintenance is for 12 to 8 months. Then coming back to our case, again, you may remember that 43-year-old male healthcare worker with exertional shortness of breath and hemoptysis. So the investigation panel were normal, chest X-ray normal, bit of a subtle changes there. So we repeated the investigations at NHRD and this looks normal. This is the X-ray he came with, and this is the X-ray that we have done there. This is the HRCT. that we did there, and we can appreciate there are plenty of ground glass opacities, interlobular septal thickening, and crazy paving appearance. So this is the diagnostic workup that we have done there. You can see the repeat chest CT, there's nothing much. The differential diagnosis only the DAH, and the CT pulmonary angiogram, and the shows there's nothing else. Even the 2D echo is normal, and the bronchoscopy, this is the actual picture that we have done there. It's clearly showed the hemocyte-related macrophages. And we did all the investigation, including anti-GBM and custodies and all, and everything was normal. So we made the diagnosis Ippc, and we started pulsing him. We didn't go for a biopsy because after an MDM meeting, we decided to go ahead with pulsing because, as I mentioned, biopsy is not needed, it's not mandatory. So a single-sided Ippc is a small vessel vasculitis, involves lung. There's no serological markers, that's why it's called post-immune, but sometimes it may come up with ANCA positivity, and the diagnosis, 100% diagnosis, we need the histology that it shows capillaritis, and it has a good prognosis compared to other vasculitis, and it usually responds to corticosteroids. So, my take-home messages: importance of the clinical history, hemoptysis, anemia, bilateral lung shadows, and exertional shortness of breath. We should look for bilateral lung shadows. Don't miss the clinical signs. A good clinician must look. We actually look for. We actually actively look and search for them. Early bronchoscopy. So please refer to respiratory people. Important laboratory data. Management of hypoxia, bleeding and ventilator support. Management of the specific conditions. Therefore, you need to see beyond lung to see the multisystemic disorder. Again, don't look through the keyhole. You have to open up the door to see the big picture. Thank you very much for your patience and kind listening. I would like to thank my supervisor mentor, Dr. Ishant Pereira, and Dr. Suhasha Silva, also to my previous mentors in my registrar training, Dr. Mrs. Vajita Lekam Vasam and Dr. Ranjit Jaisingh. Thank you all again.
Thank you, Dr. Dahanayake. Now the forum is open for questions. Do we have any questions from the judges?
We call Hemorrhage syndrome. Is that the idiopathic hemosiderosis?
Hemosiderosis, yes.
That was the Hemorrhage syndrome.
Yes, it's actually need the biopsy to confirm because there's no capillaritis, as I mentioned, sir. Yeah. Usually in young males, young adults, comes up with the massive come up with the chronic anemia. So they don't present with hemoptysis.
Oh, I see. Right. Okay. What is the relationship between organizing pneumonia and this diffuse pulmonary hemorrhage?
Organizing pneumonia, there are idiopathic causes and secondary causes. So we should actively look for other secondary causes like doing bulk. But this pulmonary diffuse alveolar hemorrhages, like in CT appearance, the radiological appearance looks much more similar. Yes. But the cause is different, the pathology is different, as I mentioned. So in the BAL, definitely we can diagnose the DAH by doing the bronchoalveolar. It's hemorrhagic, and it will be like as I mentioned, the aliquot will be with much RBCs. But in organizing pneumonia, we won't see the that RBC and the bleeding.
Okay.
But there may be association.
So in your experience, when you find possible diffuse pulmonary hemorrhage,
yes,
in HRCT,
yes,
because it's we often find the radiologists can't differentiate it from hemorrhage and other causes, as you mentioned.
Yes.
So you recommend repeat HRCT, or you want us to refer to the respiratory physician straight away for bronchoscopy?
That's I mentioned about the timing, sir. So sorry, when they present with acute bleeding, there will be ground glasses. Right, so the bleeding will settle. Then, even though if we do the CT in the acute setting, there will be ground glasses and the diffuse shadows. So when the bleeding settles, and if we do the CT in after a couple of 2-3 days, then there will be the resolving part, and there will be more than septal thickening, right? And so ultimately it will get healed. Then sometimes we may be encounter with the pulmonary nodule. So this happens in our cases. So in that particular hospital, they have done the CT and they could not see the acute bleeding. But luckily, when he came to our hospital, we repeated the CT and there were ground glass opacities and the stages. So the experienced radiologist can differentiate the pulmonary hemorrhage.
There are a couple of questions from our online audience. So something pertaining to the CTs also. So there's a question: what's the positive predictive value of Hrct in pulmonary hemorrhage, and how confidently can we say this is pulmonary hemorrhage and nothing else by doing Hrct? I think you pretty much
that
more
the
or less
figures
answered.
actually I don't know to answer, because but as I mentioned, experienced radiologist, those who have worked in respiratory units, they can identify and diagnose confidently.
Right. Okay. There's another question: how frequent does COVID-19 cause pulmonary hemorrhage?
Still, there's no data or evidence data to show, but there are emerging case reports, and the thing is there may be the diffuse shadows, and we can't do the diagnostic BAL in those patients, so we tentatively treat, but the cause may be with the ARDS, the lung hemorrhages, the diffuse alveolar damage.
I suppose if they have hemoptysis, you might be able to suspect.
But as when I went to the literature, that they didn't present with hemoptysis in COVID-19.
Okay. And when will you consider single lung ventilation in diffuse alveolar hemorrhage?
Yeah, in massive hemorrhages. So we need to do the single lung double lumen ET and ventilate. And in that cases, need a ICU setting and the need of intensives as well.
Okay. And any place for desmopressin in cases of pulmonary hemorrhage?
In DH, it's not mentioned, but if it's a parenchymal bleeding due to coagulation abnormalities, of course, yes.
Okay, in view of time constraints, so we will stop there.
Thank you very much.
So thank you, Dr. Dahanayaka, for that excellent lecture. Can you just wait a moment? There is a token of appreciation from the Ceylon College of Physicians. Right, our next speaker is Dr. Ashani Varuni Wickramarachchi, MBBS and MD in Medicine. She is the Senior Registrar in Endocrinology attached to the University Endocrine Unit, National Hospital, Sri Lanka. And she's going to talk to us on menopause or menopause, an evidence-based approach. Over to you, Ashani.
Much, madam, and thank you, CCP, for this opportunity. So my topic today is menopause or menopause. So I will explain to you later why I chose this topic for my presentation. So my talk begins with a story of a woman whom I met when I was in my faculty. So this is a 47-year-old bank executive who is a very hardworking, enthusiastic person who recently had a promotion when menopause hit her. So she was riddled with multiple symptoms: fatigue, joint pains, back pains, anxiety, and on top of that she was having hot flushes. So these hot flushes made it very difficult for her to attend her managerial meetings because it was quite embarrassing for her. And she was also having incontinence. So traveling through public transport was a nightmare for her. And she sought multiple medical consultations with different symptoms and was treated for fibromyalgia, depression, anxiety, vitamin D deficiency without significant improvement in her overall clinical condition. So as I went on in my career for the past 10-12 years, I have met multiple women like this presenting with numerous complications, with numerous symptoms, and I would always treat them for their presenting symptom and send them off until recently when I realized that this disease is, what we see is only the tip of the iceberg. There's a whole lot of hidden symptoms and hidden pathologies behind menopause that we should address if we want to improve the quality of life in these patients. So that is what I try to achieve within the next 25 minutes of my presentation. So why I chose the topic menopause? Because 50 years back, women had their children in their 18. When they were 18, they had children. So by the time they are 50, they are grandmothers, they had time to pause. But now women are career driven. By the time menopause hits them, they are at the peak of their career. So they do not have time to pause. And 35% of Sri Lankan workforce consists of women. And now the retirement age is 65. So we should really take it up to our we should really take this up as an opportunity to treat these patients and improve their quality of life. Now, if we look at the symptoms of menopause, what we think usually is the symptoms related to the reproductive tract, mainly irregular menstrual periods, dysmenorrhea, and vulvovaginal atrophy, and then the symptoms like hot flushes and maybe some mood disturbances. But is that all? No, menopause is associated with increased cardiovascular mortality. It is associated with mood disorders, which can range from emotional lability to anywhere to depression, suicide, even. An increased cancer is genital syndrome, which is quite neglected among physicians as well as in patients. And then there's cognitive impairment, sleep disorders, osteoporosis, and sexual dysfunction. So care for menopausal women should take a holistic approach. So if we look at the ethnic variability of symptoms, the African American women tend to have more vasomotor symptoms, and Asian population tend to have more somatic symptoms. So this was replicated in one of our studies by Dr. Vaidyasekara, who has studied Colombo district community dwelling women aged 45 to 60, where he has noticed a 40% prevalence of hot flushes among perimenopausal and postmenopausal women, a similar percentage of sleep problems, but 80% prevalence of joint and muscular symptoms. So these women can present to you with multiple complications, and these women tend to go to multiple specialties with their symptoms. So what is the prevalence of menopausal symptoms in Sri Lanka? So mid-year female population more than 50 years was estimated to be 2.75 million as of 2020, and out of this population about 1 to 1.5 million is thought to have menopausal symptoms. Now if we compare this with a disease like diabetes, the population prevalence in Sri Lanka is thought to be about 2.5 million, but diabetes has such a big attention in our medical curriculum. Like if we take the undergraduate curriculum, postgraduate curriculum, our examination, bulk of this is diabetes, but this important disease is quite neglected. So are we ready to treat this population? So this was checked in Mayo Clinic, the center of excellence, among their trainees. So what they did was about 93.8 trainees believed that it was important to learn about the management of menopause, but about 20% has not received even a single lecture or educational activity regarding menopause during their residencies, and only 6.8% were prepared to treat menopausal women, and 1/3 said that they would not offer menopausal hormone therapy to symptomatic women even if they do not have contraindications. So we have to agree that there's a significant physician inertia when it comes to treating menopause. What about patient factors? So this is a study that is done in North America. They have studied about 1,000 women range from 45 to 60 years, where 80% of the women had some sort of a menopausal symptom, but 1/3 had never sought medical attention for these symptoms. So we have to agree that patients also tend to take this as normal, and I'm sure Sri Lankan situation is much worse. So this brings us to my first key message, that menopausal symptoms vary and are troublesome and has a significant impact in quality of life, but are under-recognized both by the physician as well as the patient. So then we'll move on to the second part of my talk, which is menopausal hot flushes. So what are hot flushes? These are sudden sensation of heat that is centered in the upper chest and face that lasts anywhere from 2 to 4 minutes. And this is associated with profuse perspiration, palpitation, and anxiety. And this is usually followed by a chill. And the triggers include spicy food and alcohol. So if you look at the reproductive aging, menopause is a retrospective diagnosis. Let me take the laser pointer. So when a woman has a final menstrual period that is followed by 12 months of amenorrhea, we can diagnose that patient as having menopause. So it's a clinical diagnosis. But woman's ovarian reserve goes down starting from late reproductive years. But the serum estrogen levels are maintained because of increasing FSH levels. And then they enter into the early menopausal transition, where they have variable lengths in their cycle. So the cycle length vary more than 7 days. Then as they enter the late menopausal transition, they start to skip menses. So now the cycle length varies more than 60 days. And then they reach the final menstrual period and enter the postmenopause, which is again divided into early and late depending on the duration from final menstrual period. So hot flushes can occur anywhere from late reproductive years to late postmenopause. So average duration is usually 5 to 6 years, but in some women this can last up to 20 years, causing debilitating symptoms. But it is important to notice that 80% of women have menopausal symptoms in their late menopausal transition and early postmenopausal period. So age ranges between about 47 to 53, which is quite young. So if you look at the gonadotrophin levels in menopause, you can see the upper chart represents LH and FSH levels, and the lower chart represents estrogen and progesterone levels. There's quite a rate of variability day to day. And these hypergonadotrophic phases and these ups and downs in hormone levels is what triggers hot flushes. So if we simplify the physiology of the thermoregulatory center, so this is the anterior hypothalamic nucleus of the thermoregulatory center in the hypothalamus. The main mediator is serotonin. So we have two types of receptors in the postsynaptic neurons. 5-HT1 receptors, which is mainly concerned with hypothermic response, and 5-HT2 receptors, which is mainly concerned with hyperthermic response. So the balance of euthermia is maintained with this receptor balance. So what happens in menopause? So now the receptor balance is disrupted. There is more hyperthermic generating 5-HT2 receptors, and also there is less serotonin available in the synaptic cleft because of increased uptake. So if we treat these women with estrogen, what happens is we re-establish the receptor balance in the postsynaptic neuron. And if we treat these women with SSRI or SNRI, serotonin reuptake inhibitors, we re-establish the amount of serotonin in the synaptic cleft. So menopausal hormone therapy re-established the thermoregulatory response. So it is important to look at the trends in prescribing practices of menopausal hormone therapy in US. So these are data taken from US physician survey databases. And if you look at early 1990s and 2000, there was about 8 million postmenopausal population on menopausal hormone therapy. So that accounts to about 75% of the menopausal population. And then in 2002 and 2004, we got the data from WHI study, Women Health Initiative study, which showed increased mortality cardiovascular disease associated with menopausal hormone therapy. So that causes drastic reduction in practices of menopausal hormone therapy prescription. And then the safety data was re-established in 2008-2009, where they analyzed the reanalyzed the WHI data, and then there were new trials establishing the safety of these hormone therapy. But still, to date, the prescription practices of menopausal hormone therapy remains low. So what are the consequences of untreated menopausal symptoms? So that is related to increased direct and indirect health-related costs, and it reduces quality of life and productivity, causing economic burden and causes sleep disturbance, impaired sexual health, increased osteoporosis, and it leads to marketing of ineffective products like black cohosh, licorice, ginseng, which is quite expensive and marketed as bioidentical products, which are not effective. So if we look at the Menthilt initiative trial, it is important to look at this trial which has changed the landscape of menopausal hormone therapy practice. So what they did was they studied about 25,000 menopausal people, and they divided them into two groups. Women who had a uterus were treated with estrogen and progesterone combination or a placebo, or women who did not have uterus was treated with either estrogen or a placebo. So what did they notice? So if you look at the data from this trial data, so there was an increased risk of stroke among this population, and there was a trend towards an increased risk of pulmonary embolism. And in the estrogen only arm, the cardiovascular risk was neutral. There was reduction in invasive breast cancer and hip fractures. So what happened to these positive effects when we add progesterone into the combination? So the coronary heart disease risk went up, the stroke risk went up, pulmonary embolism and invasive breast cancer risk went up. So, but if you look at these numbers as an absolute number, so in the combination arm, if you treat 1,000 women with menopause, with menopausal hormone therapy combination, menopausal hormone therapy for 5 years, you will cause 3 additional breast cancers. So you have to remember that this population was not screened prior to this for the risk of breast cancer. So if you evaluate these patients for the 5-year risk of breast cancer and then start menopausal hormone therapy, you can reduce this number even further. And you have to remember that this is 1,000 women treated for 5 years and 3 breast cancers. So that is quite small. And in that time, you will be preventing 12 fractures. You will be preventing 5 deaths. And you will be preventing 5 diabetes. So, but if you look at the estrogen alone now, the benefits outweigh the risk by far, by a large number. So this increased risk of cardiovascular disease noted in Women's Health Initiative study differs completely from the observational studies like Nurses' Health Study. So what they did in Nurses' Health Studies, they took a cohort of 50,000 nurses, age ranges from 30 to 63. So this study included patients with natural menopause as well as patients with induced menopause. So the study population was quite young with an average age of 52. What they noticed was when treated with menopausal hormone therapy, there was 50% reduction in major coronary artery disease, and there was 50% reduction in fatal cardiovascular disease. So what is the difference in WHI? What's the reason for the difference in WHI? So if you look at the WHI data, the average study population is 63.2 age. It's quite an elderly population, and the average time since menopause, about 70% of women were more than 10 years past their final menstrual period, and they had very little vasomotor symptoms. So actually this study was designed to evaluate the cardiovascular and osteoporosis benefits with menopausal hormone therapy. So what they did was they excluded women with severe vasomotor symptoms because it was unethical to withhold them of their treatment. So what that did was skewed the study population to include more elderly patients, and these patients had significantly higher comorbid status in the baseline. So we were treating an unhealthy population to begin with. Then when you look at the same WHI data and divide it into 10-year age groups and look at it, you can see that majority of these adverse outcomes are congregated in the elderly age groups, and the mortality is high in the elderly age group. But if you look at the all-cause mortality in the lower age groups like 50 to 59-year-olds, the all-cause mortality is reduced. And if you look at the cardiovascular, invasive breast cancer, stroke and pulmonary risk, they become insignificant. And if you look at the estrogen alone now, it's all benefits at that point. So the key message I have to convey in this part is that the risk-benefit ratio and safety profile of menopausal hormone therapy is differed markedly by the clinical characteristics of the study participants. So mainly age, time since menopause, and comorbid status. So this was further proven in subsequent studies like KEEP study, where they studied menopausal hormone therapy in younger population and noticed that there was no progression of carotid intimal medial thickness and coronary artery calcification score as the surrogate markers of thrombosis. And then there are studies like ELITE study where they compared early postmenopausal women on menopausal hormone therapy with late postmenopausal women on menopausal hormone therapy. Now, if you look at this, the patients who were started on menopausal hormone therapy in the early postmenopausal period had reduction in their carotid intimal medial thickness, and women who had started menopausal hormone therapy in their late postmenopausal period had increase in their carotid intimal medial thickness. So this brings us to timing hypothesis, where the anti-inflammatory protective role of menopausal hormone therapy occurs only if it is started prior to an inflammatory insult. So in plaque-naive vessel, it has a vasodilatory action, but if because of long-term estrogen deprivation, if there is atherosclerosis, then it causes a vasoconstriction and plaque disruption. So menopausal hormone therapy is all about balancing risks and benefit. It has significant risk about symptom control, skeletal benefits, reduction in coronary heart disease in younger populations, reduction in cancers, but it is associated with some risk as well. So you have to always manage these risks and benefits when you're treating these women with menopausal hormone therapy. So in younger women, that means age less than 60 years, who are closer in time to the menopause onset, that means less than 10 years since menopause, menopausal hormone therapy, in addition to relieving menopausal symptoms, it reduces coronary heart disease, reduce invasive breast cancer and other cancers, and reduce fracture risk, and reduce all-cause mortality. So this brings us to my second key message, that hot flushes are easily treated with menopausal hormone therapy, and its safety in younger postmenopausal groups are well established. So do hormone therapy effects differ by formulation or the route of administration? Yes, actually they do quite few. So when we look at oral and transdermal preparations, the cardiac effects are more or less the same, similar as we consider the overall cardiac outcomes, but the venous thromboembolism risk is much less in transdermal approach. So what happens is, when oral hormone go through the liver, they induce hepatic protein production, which includes coagulation factors and multiple other proteins like sex hormone binding globulin, thyroid binding globulin. So this is the reason for increased thrombosis associated with oral prescription, but not the transdermal prescription. Breast cancer risk, fracture prevention, improvement of cognition, mood, they remain same between oral and transdermal approaches. But sexual function is actually better in transdermal, because oral hormone therapy induces sex hormone binding globulin, so they will bind testosterone. So testosterone is important in female libido, so the transdermal estrogen will negate that effect. So if you are considering menopausal hormone therapy, it is very important that you do a thorough risk assessment and select your patients. So how do you do the risk assessment? You have to evaluate for the cardiovascular risk, look for past atherosclerotic cardiovascular disease, calculate an ASCVD risk, and evaluate for past venous thrombosis and non-thrombophilic status, and evaluate for cancer risk. Now, according to Sri Lankan College of Surgeons, any woman who is more than 40 years is indicated for a clinical breast examination annually, and any woman more than 50 years until the age of 69 should have a mammography and ultrasound every 2 years. So you should take this an opportunity to take this patient and assess their cancer risk, and you have to exclude other contraindications like unexplained vaginal bleeding and active liver disease. So if your patient is a candidate for Hrct, then if the patient does not have the uterus, you have the option of treating them with estrogen alone. And there also we have several dose ranges. We can treat with low dose, high dose, depending on the symptom severity. And if the patient has a uterus, you have to combine progesterone with this to negate the endometrial proliferative effects of estrogen. So if the woman prefers a monthly bleed, there's the option of treating with cyclical progesterone, and if the woman prefers amenorrhea, continuous progesterone is better. And you have to keep in mind, in late menopausal transition, that since the women have an innate ovarian action, if you treat with low dose continuous progesterone, there is a risk of having breakthrough bleeding. So what is the response you can expect after you treat your patient with menopausal hormone therapy? So at 12 weeks, there would be about 75 reduction in frequency and severity of hot flushes. So when you stop the therapy, so that has to be individualized depending on the risk-benefit profile. So the risk of continuation menopausal hormone therapy beyond 60 years, whether it is same as starting after 60 years, we don't know it. The usual duration is 5 years, and in young women who has primary ovarian insufficiency or premature menopause, we can treat them until the anticipated natural menopause, which is usually 51 years in our country. So what about women with high risk factors and contraindications? Do we have any option to treat them? Yes, we do. SSRIs, SNRIs, as I showed, re-establish the thermoregulatory response. So we can treat them with that. And also gabapentin has been shown to have similar efficacy. So these modalities treat hot flushes, they reduce the hot flush frequency and severity by about 30 to 60%. So this brings us to my third key message, that menopausal hormone therapy require balancing risk versus benefit, and alternative therapies are available for women with high risk. So what are the other symptoms associated with menopause? So we cannot go on to talk about menopause without talking about postmenopausal osteoporosis. But the time period given to me is not enough to have a deep discussion regarding it, but I will briefly carry through important points. So estrogen is important in maintaining the net balance in the bone. So estrogen increases osteoclastic apoptosis and reduces osteoblastic and osteocyte apoptosis, thus maintaining positive balance. So when estrogen is not there, this balance is lost. So if you look at the burden, 61.5% of women over 50 are found to have osteoporosis. And annual cost of caring for osteoporotic fracture is higher than caring for a stroke or an MI. And also, osteoporosis is not just a fracture. A fracture is associated with a very high mortality. If you get a hip fracture, your relative risk of death is 6.68. If you get a vertebral fracture, your relative risk of death is 8.68. That means you are 8 times more likely to die if you get a vertebral fracture. So this is replicated in one of our study by Professor Lekam Vasam, where he studied a cohort of 1,000 women over a period of 2 years following a hip fracture. And in his study also, 1 year relative risk of death was 5. So after the first MI, the 1 year mortality is about 10.3%. But after a hip fracture, your 1 year mortality is 30%. So this is a very serious condition that needs attention. So how do you prevent this? So prevention is with maximizing peak bone mass. That is mainly with treating the younger women with adequate nutrition and improving their peak bone mass, and then identify at-risk population through screening, and then going for timely intervention. So whom to screen? Every postmenopausal woman over 50 years should get a clinical fracture risk assessment. And when to do BMD testing? Every postmenopausal woman more than 65 years should get a BMD testing. And also women with fragile fractures and other features of secondary osteoporosis. And also women aged more than 50 with additional risk factors such as parental hip fractures, diabetes, smoking, heavy alcoholism, and if they have radiographic osteopenia. So how do we treat these patients? So we have the options ranging from bisphosphonates to anabolics, but all are costly. Prevention is the key in managing osteoporosis. So genitourinary syndrome of menopause. This is a highly neglected and a disease with significant physician as well as patient inertia. So genitourinary syndrome of menopause can be in the form of vulvovaginal atrophy, which manifests as dryness, burning, and dyspareunia, or it can be in the form of urinary dysfunction, which manifests as urgency dysuria and recurrent UTI. And the studies have shown that this has significant impact on activities of daily living, emotional well-being, sexual function, and even self-image, because women perceive this as lack of hygiene. So how do you treat this? Menopausal hormone therapy remains the best approach and most efficacious approach in treating vulvovaginal symptoms related to menopause. And we have the options of vaginal estrogen for women with contraindications, and also we have options of lubricants, moisturizers, pelvic floor exercises, laser therapy for these women. A little bit about the vaginal estrogen. So this has very low systemic absorption and can be used safely even among high-risk populations such as breast cancer patients. So perimenopausal mood disorders. This is more in patients who have vasomotor symptoms, and that is related to the fluctuating estrogen levels. So if the woman has predominant vasomotor symptoms related depression, we can treat with menopausal hormone therapy. And if the woman has more depression features, we can treat with SSRI and other antidepressants. So the key message I want to convey is menopause is related to many other health-related problems, and care for a menopausal woman should take a holistic approach. So care for a menopausal woman, as I said, is not just treating the tip of the iceberg that they present with, but looking and actively exploring all these diseases that is associated with this and treating them. So this brings us to my summary, where I would revisit my key messages that menopause symptoms vary and are troublesome and has significant impact in quality of life, but are under-recognized both by the physician as well as the patient, and they are easily treated with menopausal hormone therapy, and its safety in younger postmenopausal groups is well established. Menopausal hormone therapy requires balance in risk and benefit, and alternative therapy modalities are available for patients with high risk factors. So not a single woman should be left untreated with this symptoms. And menopause is related to many other health problems, and care for the menopausal woman should take a holistic approach. So thank you, and I hope all our 70-year-olds will look like this in the future. So these are my references.
Right. Thank you, Ashani. Do we have any questions from the judges?
Okay.
Yeah,
Yes. Yeah. So when do you recommend to start hormone replacement therapy? Is it to wait for 12 months or before that? That's the first question. And for how long should it be continued?
We can start actually, as I showed you, the menopausal hormone therapy. The symptoms can start even in the late reproductive years. So we should not wait till the onset of menopause and after the symptoms onset and then 12 months to treat these women. So when they present with menopausal symptoms, we can start them on menopausal hormone therapy. And the duration is, of course, it should be individualized, because for most women we take it for 5 years. But as I said, some women experience these symptoms for about 20 years. Of course, treating them with hormone therapy for 20 years is not practical and not safe, but we have other options. So we have to always discuss with the patient regarding the risk and benefit and extend it by few years and try to tail off, and we can go for low dose preparations as we move on from the duration of menopause. And also we can add a SSRI or other non-hormonal method before tailing off our menopausal hormone therapy, so that will smoothen out the transition.
Thank you for excellent, actually it's a very good lecture. I'm not expert on this area, but I find some of the women I see here, some of them get menopause symptoms, some of them don't have any symptoms at all. They are quite okay with the menopause. Is there a hormonal difference in these two categories of women?
Yeah, like most other disease, this is also thought to be multifactorial. So there's a genetic component, environmental component, and most of the psychosocial components that contribute to this. So women who have significant family support tend to perceive these symptoms. So there are some studies, observational studies done like that, and also there are some families which very severe symptoms. So of course there are multifactorial things contributing to this. And also most of our women do not complain about these things, but if you ask them, do you have difficulty having coitus with your partner, they always come up with a yes. So I feel that it's not that they don't have it, they're not telling that they have it. So it's our responsibility to ask them about this and then reduce their suffering.
One other question. Now you said that even they probably need they are high risk of osteoporosis. Now, I think Professor Rat's studies have showed almost 50% of Sri Lankans have low vitamin D levels. So do you think that, routinely when they reach menopause, we should start on vitamin D and vitamin D therapy in these patients?
So optimal calcium and vitamin D either through diet or through supplements is has shown to have beneficial effects. So that is recommended. So not that everybody should be on a pill to get the vitamin D. So if a person is working outside most of their time, they might not need that therapy. But the person who is having quite an indoor job, who has features, and also if facilities are available, you can do a vitamin D level, you can start them on replacement therapy.
Do you routinely recommend, because most of the people can't afford to do vitamin D levels,
Yes, routine recommendations are there for postmenopausal women at risk population.
There are a couple of questions from the online participants. I think if I were to summarize one or two, what they're asking is basically what is the approach to a woman in Sri Lanka with these menopausal symptoms or perimenopausal? What is the standard practice in Sri Lanka, and also what investigations, what screening investigations that are done for them prior to recommending this hormonal replacement?
So history is the most important thing. You have to get the history of prior events, prior vascular events, prior thrombosis, and also family history of breast cancers, multiple relatives with breast cancer. So those are contraindications for menopausal hormone therapy. And we usually do a baseline fasting blood sugar, lipid profile, HbA1c, the metabolic screening, as well as a baseline mammography we arrange, because anyway it is indicated in these women. And those are basically the investigations that we do. And then we start them on hormone therapy. So that depends depends on the at the point of menopause the patient is at the moment. If they are in their late menopausal transition, usually, and if they have an intact uterus, we usually tend to treat with a higher doses because they have an innate ovarian function. So we have to give doses that would bypass that to suppress the ovarian function and reduce the symptoms. So that is, and then as they go on in the cycle, as they grew old, we can reduce the doses and come down. So we have actually, I don't know whether it's okay to tell the brands and everything, we have estradiol tablets, we have estradiol mono tablets where we have the single pills that contain the estrogen only, and then we have the combination trials, and that also we have this continuous trials, where we have the continuous progesterone in that pills, and then we have the combination pills that does not have the continuous, that is only for 14 days we have progesterone, then 14 days there's a gap, so that will cause a bleed.
Okay, I think you may have answered this already, but hormonal substitutes from plants available and are marketed, and are they of any use, especially evening primrose oil?
Yeah, so there are, if you type as menopausal hormone therapy available in Sri Lanka, I think you get 2 photos of actual drugs, but the whole lot is all supplements and all these things that is marketed. But trials have not shown this. Trials that they show us is usually the very small number observational studies with very insignificant benefits, or usually what they show is non-inferiority, but the guidelines does not recommend prescribing them in women, and they have not shown consistent benefits throughout trials.
Right. Okay, thank you very much.
I would like to take this opportunity to thank CCP as well as my mentor, Professor Prasad Katlanda and Dr. Uduka Bilgahapitiya and Dr. Maneka Sumanatillaka and Dr. Sivadashiya Padmanathan, and as well as my previous trainers, Dr. Thirumavalan as well as Dr. Dhanapal Disanayaka and Manohari Senaviratna, for immense support they have given and for the guidance they have given. Thank you.
Right, okay. Thank you very much. And we would like to present a certificate of appreciation to you from the Ceylon College of Physicians. Right, thank you very much. And that concludes the Young Physicians Forum.